My name is Sahai. I'm a consultant urologist and honorary senior lecturer in the Department of Urology, Guy's Hospital, King's College London, King's Health Partners. We are very grateful to the BJUI for making our paper Article of the Week. The Changing Fate of Urinary Incontinence Surgery in England, a perspective from the Hospital Episode Statistics Database. The authors on the paper are John Withington, Hirji, and myself.
My name's John Withington. I'm a Urology Research Fellow. The aim of this paper was to quantify changes in surgical practice with regard to the treatment of urinary incontinence. We looked at three key areas: stress, urge, and post-prostatectomy urinary incontinence. We used publicly available hospital episode statistics data and interrogated data from 2000 to 2012. We identified for urge urinary incontinence a steady increase in the use of botulinum toxin A and neuromodulation from 2006 to 2012. This coincided with a significant decline in the use of clam ileocystoplasty. Treatment of stress urinary incontinence, we identified a steady increase in the use of synthetic mid-urethral tapes, including tension-free vaginal tapes and transobturator tapes during this period. This coincided with a steady fall in the use of colposuspension. During the same time period, we also observe a significant increase in procedures to remove synthetic mid-urethral tapes, reflecting complications from these. Finally, in the time period studied, we observe a significant rise in the use of artificial urinary sphincters in men, reflecting the widespread uptake of radical prostatectomy and its complications. These findings must be interpreted in the light of the limitations of HES data. These data are first only as accurate as the coding that generates them. It is difficult or impossible to differentiate trends in surgical practice, for example, from trends in coding practice. Having acknowledged this limitation, the data do reflect trends that have been observed by experts in the field.
As to refractory overactive bladder and urgency incontinence, we can see that both NICE approved treatments such as sacral neuromodulation and botulinum toxin A are on the increase. However, when we analyse the HES data in further detail, we can see actual hard data to suggest the use of botulinum toxin A far outweighs the use of sacral neuromodulation. And there are several reasons for this, which could be related around commissioning and finances. It's important to monitor these trends, and in the current era with problems that we're hearing about with the use of mesh in urology and urogynecology, we may well even see increases in the use of colposuspension in times to come. The HES data will give us important information to inform discussion about workforce planning, training and subspecialization. Many thanks for your attention.